And I'd like to call on each of you. That.
It's Hadass Bernard. I'm very happy to be here and chair of one of the network agencies, which is JVS Human Services, and they are very involved with people with developmental disabilities, more on workforce development. And then I also have people in my family with mental illness, and also a first cousin who's 25 years old who has intellectual and developmental disabilities, and I've been an advocate for her all my life. So I'm also involved with the homeless community, and person who's used services and been really involved with Oakland County and lived in Oakland County all her life. I'm very happy to be here to represent really everybody in Oakland County. So I hope I can help everybody in any way I can.
Hi, I'm John Paul Torres. I'm a past board member. Going back about 8 years ago, I served on the CMH board for a term. I'm a school board trustee out in Waterford School District, vice president of the school board. I work as a court administrator in Washtenaw County and oversee services for juveniles in the youth justice system, primarily juveniles affected with substance use disorder. And I'm really excited to be on this board and serve Oakland County again in this capacity. Thank you.
Sarah?
Hi, my name is Sarah Guadalupe. I am a social worker by trade. I currently am the Director for Disability Support Services at Oakland University. I'm part-time faculty at Wayne State University in the School of Social Work. I have experience working with those with mental illness. I have a particular interest in, I'm actually completing my PhD in early childhood education, so I have an interest in research. And I have experience working in Common Ground in the past, in some of the area emergency rooms doing, I had experience working with those in Oakland County and Wayne.
Very much, and to all three of you, we welcome you aboard. At this time, we'll call the meeting to order. Roll call.
Ms. Summers?
Here.
Dr. Taub?
Here.
Ms. Newman?
She is here. She just left for a moment.
Dr. Hans will be absent. Dr. Klotz?
Here.
Mr. Rubin?
Here.
Ms. Kucharik? Mr. Landsman? Mr. Furman will be absent. John Paul Torres?
Here.
Sarah Guadalupe? Hadass Bernard?
And the next item is the approve the agenda. I don't think we can vote on it here. And well, this is our first of two opportunities for public comment. Is there anyone in the audience that would like to make public comment at this time? Don't see any. So the first item on the agenda is the Michigan Department of Corrections and Substance Use Disorders update from Cristina Nichols.
Good afternoon, everyone. Nice to see the board. Haven't been up in front of you in a bit of time, so I would like to give you an update. I was asked first to give a Michigan Department of Corrections update for those of you that were on the board, and to give a little bit of background to our new board members, is that the Michigan Department of Corrections approached the prepaid inpatient health plans to engage in a direct contract to manage the substance use disorder services for the Department of Corrections. So myself, the CEO from Region 5 and the CEO from Region 4 became a part of the executive leadership team to negotiate this contract. What subsequently happened is that 4 of the 10 PIHPs withdrew their interest in this contract. Michigan Department of Corrections was not interested in a bifurcated system, and so they went back to the drawing board, and they actually met with the Michigan Department of Health and Human Services to discuss potentially running the funding through the MDHHS contract, or Michigan Department of Health and Human Services contract, and then they would subsequently move down to the prepaid inpatient health plans. Director Washington, who is the director of the Michigan Department of Corrections, approached Governor Whitmer when she came into office and discussed her desire to do this, of which the governor did support that plan. So the Michigan Department of Health and Human Services and the Michigan Department of Corrections began discussions to engage in a contract. What will happen once they come to an agreement is that then the Michigan Department of Health and Human Services will engage the prepaid inpatient health plans in a negotiation process. At this point, that's what we know. We have not been approached by the Michigan Department of Health and Human Services. We are waiting for that to happen. So just wanted to give you a quick update that all last year, the negotiating of the contract unfortunately came to a halt, and now we are waiting to see what will happen with the department. The other thing I wanted to update everyone on is how Oakland Community Health Network has addressed the opioid crisis. I think we all know, and in some way are familiar with, whether it be family members, friends, or colleagues that have been impacted by this significant crisis. Michigan definitely has been impacted by the crisis as well, and had a large increase in opiate overdose deaths throughout the years. When we started noticing this, it was prior to coming to the Oakland Community Health Network. We were a part of Oakland County, and we started seeing all of our admission data changing. So for 30 plus years, the number one reason people sought treatment was for alcohol use disorders, and then for heroin and prescription opiates, and then cocaine use disorders, et cetera. And right around 2010, we really started seeing this rapid increase in requests for services for opiate use disorders, primarily prescription opiates. And then it changed again to primarily seeking services for heroin use disorders. And it increased at an extremely rapid rate. And we saw that all around the state of Michigan. At the same time, we saw a rapid increase in opiate overdose deaths as well. So we started engaging in all sorts of brainstorming and researching what we could do to address the issue in Oakland County from our perspective as the substance use disorder funding body. And we knew we needed some innovative solutions. Then it's 2014, and the law had passed, and we were merged into Oakland Community Mental Health Authority at the time, now Oakland Community Health Network, and we just increased those discussions, and I approached leadership here, of which they were extremely supportive, that we needed to add services to address this epidemic. Number one thing is we need increase in access to treatment. So we took a look at how many screenings were occurring, how quickly someone could get in for a screening for substance use services, and we saw that it was taking about 48 hours, sometimes when we were really backed up, to even get a screening for services. That could not continue to happen. So we looked at our staffing patterns, we added a staff person in access, and we also partnered with Community Corrections for a 50% paid position by this organization and 50% paid by the county to be embedded in Community Corrections, since so many individuals were coming there that were in need of substance use services. She also conducts mental health screenings as well. The second thing is we wanted to really address the opiate overdoses that were occurring in the county. And so we worked to create the Law Enforcement Response with Naloxone program, which was initiated early in 2015, and that was equipping police departments and law enforcement organizations with Narcan or naloxone to carry with them, as about 88% of the time, law enforcement is first on the scene when an overdose occurs. We created a Train the Trainer program, and so we could train large amounts of police agencies, and they could go back and train their entire force. And since that program, we've had well over 400 lives saved, which is very exciting. The other thing is we needed to get information out there to the community. We've always done media campaigns, but we did media campaigns times 10. The worst thing you can hear is when people say they haven't heard of us or how they can access services, especially since we're able to assist people who are underinsured, have no insurance, or who have Medicaid or Healthy Michigan plan. So we engaged in numerous bus and billboard advertising, an Imagine Theater campaign because it was really targeted towards youth. So every time they went to Imagine Theaters, there was digital messages right there when you're ordering your popcorn, which I believe helped tremendously. We did radio advertising, cable TV, Metro Parent Magazine. We put messages on prescription bags at Kroger stores. And I have spoken more in the last 3 to 4 years than I have in my entire career because we wanted to get out in the community and teach people about what was happening. The other thing is we started adding additional community supports. One is the Recovery Information Support and Education Center, or as some people know as the RISE Center. And that is open to anyone in Oakland County who needs some case management services or linkage to any services or supports, as well as people there in recovery or recovery coaches to assist with answering any questions about treatment, about recovery, or any early intervention, et cetera. And so that they are a very busy unit and they help a lot of people. And one of the primary reasons they help people is to link them with access to health insurance, which has been a very, very important thing for individuals with substance use disorders. We had some access to some grant money, but one of the things we wanted to do is be very calculated in how we applied for the opiate grant money. And so we wanted to apply for funds on things that we intended on sustaining. And one was transportation for treatment services. If you look back in the strategic plan or older annual plans, you'll see that transportation services was a part of the substance use annual plan in the past, and especially an increase in access to opiate-specific treatment services. And so we engage in this with our medication-assisted treatment providers who are providing treatment to individuals with opiate use disorders. And they are able to provide bus tickets to individuals. They engage in contracts with Uber Health or Lyft, and they provide that. And sometimes they also use cab companies. And that has been very, very helpful to individuals who really struggled with that. It also allowed us to really refer people to medication-assisted treatment, which the outcomes are showing to be the best possible outcomes for treatment of opiate use disorders, where people didn't have transportation before, so therefore wouldn't seek the service. Now they're able to seek it. The other thing is, I always wanted, but it became especially important when we started seeing such a rise in opioid overdose deaths and admissions, was immediate access to treatment. I wanted a person to be able to come in at any time, and when they say they need treatment, really be able to be sent to treatment. And so we opened the Sober Support Unit. It was a concept we came up with probably I would say about 6 years ago now, and then we did a request for proposal, and Common Ground was awarded the contract. So individuals who are at risk of relapse, have nowhere to go, want immediate treatment, can come in 24 hours a day, 7 days a week, 365 days a year, and will be transferred to treatment within less than 24 hours. So an individual will come in, they have a place to sleep and be monitored. If they are struggling with significant medical issues, there are paramedics on staff, as well as recovery coaches, and the staff will determine if they need to go to the hospital for medical clearance, but they can always come right back and then be transferred to treatment. Very rarely does that happen. It's just there as an option, and the paramedics know what to do and when it's important to engage further medical services. That has been extremely successful. We are now getting people in within less than 24 hours, and that is whether you come through our Access Center or through the Sober Support Unit. Honestly, a person chooses when they want to enter treatment, and that's how it should be. That it's available immediately, and that it's a person's decision when they want to begin. We also begin our jail medication-assisted treatment program. There's a high rate of overdose deaths when released from incarceration. It is one of the most at-risk times for an individual with a substance use disorder. And so we also knew that there was individuals that would come into the jail already receiving one of the FDA-approved medications for opiate use disorders. And oftentimes they would just have to immediately stop those medications because they were not offered as a part of regular medical treatment in the jail. The jail medication-assisted treatment program allows a person to continue on their medication should they come in on that medication, or if they wish to be a part of the program and they haven't, they can be seen by the doctor and nurses to determine if one of the 3 medications are appropriate for them, which is really great because of the high outcomes we see with this service. In addition to the medications, though, it is very important that a person has access to treatment services. So there's peer recovery coach services, individual treatment services, and group treatment services that are offered until a person is released. Upon release, they are followed by our recovery coach until they make that first appointment. We also have, which was one of the last part of our goals, but not last in terms of importance, just of obtaining our goals, which is to provide education and training on overdose reversals, and then also the medication Narcan or naloxone to people in our community. So our prevention provider, the Alliance of Coalition for Healthy Communities, they run our overdose education and naloxone distribution program. They customize training for all community members, and they have resources for families and loved ones struggling with addiction. And they have a direct connection with local EMS and all of the coalitions around Oakland County so they can get the message out. They have done numerous trainings, and we're looking at a prediction of about training 400 people a month is the goal. So they're very busy, but they are also getting more medication out there. Should a family member or person have to use the medication that they're given once trained, they can contact the Alliance of Coalitions and receive an updated packet of medication as well. So one of the most exciting things is when data shows that some of the things we're doing in this community are actually rendering some results. And so the first piece of data I want to draw your attention to is that we realized in 2017 actually almost 29% decrease, because it was 28.8%. I like to round up, but you know, that is semantics. 28% decrease in overdose deaths in Oakland County. That is the first decrease in deaths since 2008, and so we have been working very, very diligently to provide services. But I would be remiss in saying it's not just the substance use disorder team. It is many departments within Oakland Community Health Network that have worked together with us to see all these programs come to fruition. It's our amazing provider network who've stepped up to increase access to treatment so that we can get people into treatment within 24 hours or less. And it's our other community partners, such as our law enforcement partners and our health division, that have been very supportive throughout this process. And I think collectively, that has resulted in this decrease, which we are very excited. We are also seeing, and I can report on it later, a major shift in our data as well in terms of admissions. What we're seeing is people with opiate use disorders entering into treatment, staying into treatment, and getting better. And no longer do we see that major shift of the number one reason people are seeking services for opiate use disorders. It actually has changed back to what was, I guess, the norm for Oakland County for, I said 30 plus years, which we have more people seeking treatment now for alcohol use disorders than opiate use disorders. The reason why that shift is significant is, one, because what we see is people staying in treatment and becoming healthy and entering into recovery. But two, because the trend and increase in admissions was so significant and so quick, it's nice to see it stabilizing out and kind of being the same trend that we've seen for many years in the past in terms of who's seeking treatment with us. It's just really nice to know that people are getting better and we're losing less people this difficult epidemic. So wanted to bring that to your attention. Some very exciting information that we received. Now, I just want to quickly give a recap on services. I was asked to just give a real quick recap on the services that we contract with providers to deliver in the substance use network. One thing that we provide is prevention services. We have 8 prevention providers that cover Oakland County, and one large prevention provider, the Alliance of Coalitions for Healthy Communities, that is the umbrella organization that oversees 19 community coalitions throughout Oakland County. We fund all of those services, and the prevention provider as well. It serves 55 plus communities in Oakland County, so we have nearly all cities, villages, and townships covered in Oakland County with prevention services and community coalitions. They also have a recovery support network of 5 different meetings that cover all quadrants in Oakland County that is open to anyone. It's called the Shatter the Stigma Recovery Support Group, and family members, friends, individuals in recovery all attend, and it is a very, very positive support group for individuals in Oakland County. We also facilitate a community needs assessment every 3 to 5 years to determine what the priority issues for prevention services are in Oakland County. That needs assessment is coming up next summer, and so we will be reaching out to various sectors in Oakland County to become a part of that needs assessment with us. So our traditional substance use disorder treatment services. We have our traditional outpatient services, individual, group, family therapy, early intervention services, case management services, and one of the most helpful services are peer recovery coach services. It is, I don't even know how we would have the level of services and success we have without the peer recovery coaches. I can't even imagine a time without them, even though they've been around relatively a short period of time or something that we've been able to fund. And so that is very exciting for us. They do amazing work in the community. Recovery housing, to date, after our last request for proposal, we have 9 recovery houses in Oakland County, in Madison Heights, the Pontiac area, and in Milford. And then we have medication-assisted treatment that I spoke about, which is for individuals with opiate use disorders, which is a combination of medication and behavioral health services. Withdrawal management, or what used to be called detoxification, is really a medical service under the supervision of a physician, and it really helps to reduce withdrawal symptoms. And so when an individual with an alcohol use disorder or an opiate use disorder or some other medications such as benzodiazepines, which is Xanax, when a person is really struggling with addiction, they will have withdrawal symptoms. And it's important that we take away that pain and suffering from an individual because it is truly very painful. And so that is monitored by a physician to reduce those withdrawal symptoms. Generally, when someone is in withdrawal management, they transfer after their symptoms are relieved. They transfer to residential treatment. And that is a level of care that is one of our highest levels of care to stabilize an individual, introduce them to the treatment process, and prepare them for the full continuum of care, which is a transition to outpatient services. One last thing that I want to mention are our women's specialty services. Women's specialty services are a very specific type of service. If you are a women's specialty provider, you have to be designated by the state and you have to fulfill a very specific criteria. One of our number one priority population are pregnant women. Pregnant women is a drop everything and get them into services immediately. That is also, it's considered a priority population by the Michigan Department of Health and Human Services. Not hard to understand. And so we literally drop everything and get a person into treatment, whether they're requesting outpatient services or if they're requesting a higher level of care. Traditionally, women's specialty services were just that, women with young children or pregnant women. Women with young children, if they need residential treatment services, they can bring their children with them. Or in outpatient services, their children can attend as well. One of the things to be a state-designated women's specialty provider, you have to provide transportation, you have to provide therapeutic services to mom, but therapeutic services to any children, access to prenatal care, case management services, outreach services, you name it, everything is wrapped around an individual. But I would be remiss in saying these services are no longer only available to women. There has been a shift over many years that women are not always the primary caregiver for an individual. So one of the things is they adjusted the criteria. And if there is a man, for example, that is the primary caregiver to children, they are available for these services and the funding through these services. Or if it's any primary caregiver, if it's a grandparent that is has sole custody of an individual and they have a substance use disorder, they can have access to these services as well. It's just primarily, for many years before that, it was women. So I hope I didn't speak too fast, but I am trying to adhere to my time limit. So at this point, if anyone has any questions.
Just in regards to the SSU unit, how many individuals would be, or is there a certain amount of capacity for that?
There are, what you can say, 10 beds, but because our providers have opened access time, it's rarely full because people are being transferred to treatment so quickly. So there are 10, but we also have providers who are contingent providers should the unit ever get full.
And then is there a, is it unlimited for individuals to come back, or is there a certain amount of times that?
Nope, this is a service to the community. If you need assistance, you can come right into the sober support unit.
I want to go back to the jail aspect here. And you mentioned that in order to make sure that people are engaged in treatment prior to their release, that the recovery coach does follow along. And I just wondered if you could tell me a little bit about what that follow along looks like for someone.
Sure. So there's also a part-time staff member in the jail because they have the immediate access to when releases are coming up, what happens if it's a sudden release, et cetera. And so that person and the recovery coach work together to receive all of the information and seek releases to send everything to that provider where the person will go. So immediately when the release happens, the jail staff person contacts the provider, lets them know they're coming. The recovery coach focuses on contacting the recovery coach at that medication-assisted treatment agency and kind of a warm transfer, and then speaks with the person every day until they show up. Generally, we're trying to make same-day appointments or appointments the very next day because we see that that works best. So it is rare that they're not going pretty much immediately to that provider. Sometimes with the unscheduled releases that we don't know about, it may take the 24-hour period because we didn't know they were being released. But for the most part, it's very scheduled when we know the person's being released, and then they can go. And sometimes the recovery coach has driven a person to their first appointment as well. Mm-hmm.
Well, thank you so much for everything you're doing, and that you did the media campaign and education is wonderful. I was just wondering, you talked about the Imagine Theater advertising for youth. Are you in the schools? Are you in the colleges? And if so, how do you address them.
Sure. Now, this could be a presentation all
Oh,
in and of
okay.
itself, but our
Okay.
prevention providers, several of our prevention providers are delivering evidence-based services in the schools. And so educating individuals, doing programs called, for example, Life Skills Training, which is a nationally recognized evidence-based program. Strengthening Families is another program that's been done. So we have 3 or 4 providers that are directly in the school, and then the Alliance of Coalitions for Healthy Communities has a college program as well, and they're in Oakland University providing services as well.
About the RISE Center, Recovery, Information, Support, and Education. So where is that? I'm not familiar
That
with
is
it.
actually in our Access Center. So the Resource and Crisis Center has many services within it. It has Common Ground Crisis Services, it has our Crisis Residential Unit, it has all of OCHN's Access, and several other programs as well, but the Sober Support Unit and the RISE Center are housed within there. They also do a lot of phone information as well. People call the RISE Center all of the time in case they can't get physically into the RISE Center. And then individuals that are there for access or other reasons, a lot of times come in there to get additional resources, or if they haven't applied for benefits of any type that they need, they'll stop in there after their appointment and receive services as well. You're welcome.
A question about the peer recovery coaches. So is that administered through one of our providers, or is it who administers?
Very good question. Yes, it's through our providers. So right now, Sacred Heart Health and Wellness Center, they're actually located in Madison Heights. They're importing all of the treatment services, medical services and nursing services, and recovery coach services into the jail at this time. And then in terms of recovery coach services in general, all of our providers employ recovery coaches both at the outpatient and residential level.
Cristina, how strong would you say our relationship is with the county emergency rooms with our programs? Is it strong? Is it, how effective is it for people to make it to our program?
So that is an excellent question. I have been working with the emergency rooms for quite some time now. Some of you may remember I've talked about wanting to launch an evidence-based program called Project Assert. That takes a lot of education and numerous meetings to really help emergency rooms understand the benefit of importing recovery coaches into an emergency room. I have recently been in front of the Medical Control Authority, which is all of the emergency departments in Oakland, to present on this program, to seek any additional support or any hospitals that are willing to engage in this with us. So we've been working on trying to get in the hospitals for a little bit of time. We are making some good headway. Last Monday, I attended a meeting at St. Joe's Hospital last Monday morning to discuss this specifically. While in the past, we had been told we're not ready for this type of service anymore, they're now coming back to us, and I have another meeting scheduled to get this moving. And then they said, how about not just the emergency room, how about all floors in the hospital? So, hey, I'm excited about their renewed interest and excitement. So that is not rare. I've gone to a few conferences and saw presentations on Project Assert, and each and every time they said it's a new service for the hospital, so it took some time and education. So I think we're just experiencing the same things that people experience all around the country. We will get there. So that is our intent. What I did find from many of the hospitals is that the Sheriff's Department rides for recovery. They have been calling the Sheriff's Department to pick people up from the ER, and then the sheriffs know to take them to the Sober Support Unit. So that's effective. We could just be even more effective if we had recovery coaches embedded in the hospital ERs for people with any substance use disorder. So we're getting there.
was just, I just realized that some of our newer board members may not realize the Access Center that was spoke about, or the RISE Center, the Sober Support Unit, those are all located at that Oakland County campus off of Telegraph. So we have another building over there where so many of these services are offered. And then the question about the youth and the education in schools, I know, is it the youth coalitions that have developed their own educational videos meant to be like youth-to-youth education, and we've seen a lot of those in our staff meetings. And they're put together by young people trying to share the message of sobriety and healthy living to young people, so.
That's the PEEPS program through the Alliance of Coalition for Healthy Community. It's essentially peers educating peers, and they do that. But we also have Student Leadership Services, which is an all-student-based, with obviously adult support program as well in the schools, and that's been highly successful as well.
They're really cool videos. We watched them at our staff meeting, and some of us felt really old watching them, but nonetheless, they're effective with youth to youth, so that was good work.
You brought that up about where the building is located. It's right behind.
Yes, I apologize for that.
I'll tell you one thing you don't have to apologize for, the work that you do. And for those of us that have watched you and how you've brought this program that you've been working on to the.
Thank you very much.
Our next topic is the training update. Tricia, I'm not going to say your last name because I might blow it. Zizumbo?
That's exactly right.
How many points?
Thank you. This is actually my first time presenting in front of you guys. Last week, I started my 8th month here, so I've been watching for a while. Cristina set the bar kind of high, so hopefully I can follow that. I come actually 8 months here now. I come from the county, so I spent 12 years at Oakland County, 2 years at Children's Village, the other 10 at the Health Division. Before that, I was at Ionia County, all in health education, health communications, a lot of health-related education and training. So I hope to bring a lot of that here to OCHN. I do want to start with introducing, oh, is my picture not going to come up? Oh, there they are. I want to start by introducing my team. So this is a brand-new department. It started when I started, and I was able to get some staff and a lot of other items from a couple of the other units and departments. So I wanted to first give a shout out to my team. They are amazing. They started with me when I came and just, jumped in the deep end and kept going. So we have Menachem and Sherry, which are my full-time trainers. And then I have a few part-time staff, Sherry, Cheryl, and Beth. So I do have Sherry, and Cheryl all on my team. I only mess it up a couple times a day. And then we also have 3 contract trainers that don't live within my team. They live under Vicki Suter, but they go out and do trainings within our residential homes as well. So wanted to acknowledge them, but I couldn't get everybody for one picture. So I only got the Sherrys, Cheryl, and Menachem. One of my first orders of business, I guess, when I got here was to really start a training strategic plan. And I didn't realize coming in from the outside how big OCHN was. I had been working with them for many years as a partner, but once I started working here, there was a lot behind the curtain that I did not know. There's a lot more staff. I thought there was only about 50, 80, and there's a lot more than that. So I've been really getting out and meeting everybody, going to a lot of meetings, trying to streamline the training, really conducting some needs assessment and seeing what is being done, trying to standardize our evaluations and look at process and outcome evaluations so that we can measure our success and see how we can improve. And looking at how training connects with our OCHN's 3-year strategic plan and the annual plan. I went through it about 3 times. There's not a training goal, but I do see how training intersects with each goal that is within our strategic plan, but then also our annual plan. So I'm hoping that's job security. Give you a little overview of what I've kind of structured the training department in, is I look at it as there's 4 different items underneath the training. So we have our network training for our providers and the people that we serve. We have our trainings for the community. We have training contracts for our direct support professionals, and then workforce development, which is training for our internal staff. So our direct support professional contracts, these just came under OCHN about a week before I started, I think, October 1st. And these are with MORC, which is Macomb Oakland Resource Center, and TTI, which is Training and Treatment Innovations. So I have been reviewing their training materials, looking in depth at their curriculums, their budgets, their data, just to see, making sure that we're doing what we say we're going to do, we're getting the biggest bang for our buck, and that we're able to vet the materials, that they, adhere to the state training guidelines. I also sit on the state training guidelines work group so that we can work towards reciprocity with all counties in the state when it comes to direct support professional training. And then, of course, assessing their overall outcomes, performance of those contracts as well. Our network trainings for our providers and the people that we serve, I've been conducting some needs assessment with our providers. We can see what it is that they're offering, what it is that they're looking for from us. Looking, of course, again, to streamline that process, really trying to get my arms around all the training that is being done within our network, within our agency, within our community, evaluating our current and past trainings and looking for feedback and ideas of how we enhance our trainings and look for ways to improve. This is just some preliminary data from the provider assessment that I did with our residential care providers and some of our vocational and non-vocational providers. Out of the, I think, 110 or 108 contracts or emails that we sent it out to, I got about 50% response rate. 64% of them get the majority of their direct support professional training from MORC, and they're ranking them at approximately a 3.8 out of 5. About 21% are receiving training from TTI and ranking them at about a 4.2. And just for some background knowledge for some of our newer board members, MORC, their trainings are more towards the intellectual and developmental disabilities, and TTI's is towards mental illness. Our community trainings, been reaching out to a lot of partners and collaborating with them. We've collaborated with the county, with the Oakland County Bar Association, with Oakland Livingston Human Service Agency, Oakland University, Lighthouse of Oakland County, all to provide trainings either within the people that they serve or with their staff. Also reaching out to special populations, so law enforcement with our CIT, which is Crisis Intervention Team Training, court and lawyers, not only the Bar Association, but also looking at working with our liaisons that are in our Access and Acute Care Department, and partnering with the judges and the POs, probation officers. I'm gonna have to use a lot of acronyms. And then also creating some trainings for interacting with our deaf community, older adults, youth schools, colleges, and universities. So some of the training, did I make sure? Okay. Some of the trainings that we're offering. So we do offer mental health first aid, which is an 8-hour training. We do youth and adult. Right now, we have one person trained in higher education, but I'm getting 2 staff trained in older adult and veterans so that we can offer some mental health first aid trainings to those populations. I have staff who have lived experience, and they go out and they do trainings and educational presentations. That's the Living Hope series. They work with individuals served with Moving Forward, RAP trainings. New since I got here, we will be offering the LEAP training, which is an evidence-based training. Listen, empathize, agree, and partner. We will also be doing ASSIST, which is Applied Suicide Intervention Skills training. And we do about 7, 8 new hire trainings a month for recipient rights. Bringing in employment first trainings to advocate for people served to be in competitive employment, and as well as the crisis intervention training for law enforcement that I mentioned. I wanted to let you know how you sign up for all these trainings. So on our website, we have a training webpage, and if you click there, you're going to see our wonderful webpage. You can join the email list there to receive all my email updates of upcoming trainings, but you can also click on the graphic to view our training flyers, but I'm also looking to link as a one-stop shop for trainings. So our online trainings that are available for due process and recipient rights are linked here. Our training for direct support professionals with MORC and TTI are also linked here, and hoping to link community trainings that maybe we aren't holding, but our partner organizations are holding, and being able to have just one web page where somebody can go to find all of the trainings going on for mental health and intellectual or developmental disabilities. And then, of course, gathering our feedback and evaluation. I'm really big on evaluation and assessments and making sure that we're collecting that feedback so that we're constantly looking at what we can improve and how we can enhance and getting the feedback of our target population. Workforce development for our staff. It's been great in this position. Is I like that I get to interact with every single unit, and I get to get out and interact with all the staff and look at what it is that they need in order to stay up to date on best practices in our field, looking to identify gaps in knowledge and skills, bringing them trainings on safety. We've done an active shooter training. We're doing a stop the bleed training. I have a women's self-defense class coming up with the Oakland County Sheriffs. Bringing in some community resources that maybe I've been able to bring from the county to them. And then also professional development and increasing our CEU opportunities for staff and also our provider network. I did do an assessment of staff in January, and this is the top 5 topics that rose that we'd like to focus on when training our staff. So data analysis was one of them, supervisory skills, managerial skills, data analysis, but also stress management. So looking at different professional development trainings, but also how we make sure that our staff are receiving the skills and education to maintain their own well-being as well. I wanted to provide an infographic of some of the trainings that we've done, and this data has already changed since I created it a week ago. So since October, we've done 129 different trainings, reaching almost 3,000 people. We have an average of about 21 people that attend our trainings, and that varies. Sometimes we have 70, sometimes we'll have 6, and I'm including our group home, our specialized residential trainings as well. The 85.5 CEUs offered is actually 117 now. We have done 22 different trainings offering 117 social work CEUs since October. So I'm working on getting the amount of people that have received that trainings, but we really want to be able to increase the opportunity for people in our network and our staff to receive those continuing education credits. And then starting in February, I started a standardized evaluation of all of our trainings. So every month, if you've attended our training, you'll receive an email from me asking you to fill out a survey and give us the feedback on our training so that we can improve. So far, out of 11 different trainings, I've gotten 114 at that time. I think it's 146 when I checked this morning. And one of the things I'm really looking for is that we're making an impact and that we're not just holding trainings, and it's great that we had 100 people show up, but that we're really making an impact and we're really increasing knowledge. So asking some of those questions. So I'm happy to report that we are. People are reporting that they are having an increase in knowledge after attending our training from 3.57 up to 4.74. And they are rating our training format, so whether it's in person, whether it's online, whether it's a blended, and we are receiving a 4.5 in that. So that is my update. I think I have my first one out of the way. I can be over being nervous now. So are there any questions?
You certainly did a fantastic job in presentation. Appreciate that. Are there any questions? Yes.
Question, just a comment, just to say what great work your team is doing. I was presenting at Oakland Schools last month with the transition, Oakland Schools transition on employability
Monaco.
at the same time.
Yes.
And there was just great feedback from those folks that attended.
One of my goals is to, we have this wonderful space here to provide trainings, and I think that's wonderful, but I want us to be able to get out into the community. We've done trainings at Oakland Schools, we've done them at Lighthouse of Oakland County, really trying to do that more collaboration with our partners. I love having everybody come here, I love when this building is bustling, but really trying to bring our outreach outside. And also looking at different times of training, so looking at hosting them on different days, different times. I threw out the weekend trainings to my staff. You know, I'm warming them up to some of those, especially for recipient rights and our direct support professionals, really trying to meet those professionals where they're at and the training that they need.
I apologize, I missed part of your presentation. I don't know if you referenced it or not, but are you coordinating the trainings along with the core agencies to see where they may be doing things that you're considering doing or already doing to help to make it more efficient?
Yes, I will be. I've started provider assessments with, first I started with specialized residential, but we'll be working with the core provider agencies as well. I'm going to be tackling our cultural competency training plan as well, and plan on doing a lot of work with them to see what is already being done. Kathleen can tell you I'm pretty frugal when it comes to budgeting, so I definitely want to make sure that we are not duplicating and that we're doing more partnering and collaborating for that.
I'm glad to hear that because I'm also involved in community education, so I'm sure we'll be talking. Thank you.
No, I'll be tapping you.
Well, seeing no other questions, thank you very much again.
Thank you very much.
Thank you. The next presentation is May is Mental Health Month, and Christine Burke is going to give us some more information on that.
Good afternoon, everyone. As in the past, I am here to bring up an update to you about May being Mental Health Month, to talk about activities and initiatives we have in the community to bring awareness about this important event, which will include at our board meeting presenting you with a proclamation for your approval. I asked Debbie to join me today. She's on my team because she has been so instrumental in leading a lot of the efforts that we've introduced to the community this month, so I thought it appropriate that she share this information with you as well.
Afternoon, everybody. My name is Debbie Wisser, and as Christine said, I work on the communications team. Some of the initiatives that we've done for May as Mental Health Month is we sent letters to all the cities, townships, villages in Oakland County asking for proclamations. So far, we've received 13 different proclamations, and I'm sure we'll have more yet to come. We've done a social media campaign posting to Facebook, Twitter, LinkedIn, and we get a lot of likes, especially on our Facebook account of all our postings, so that helps. We've done press releases to the commissioners, legislators, our providers. And just last week, we did Walk a Mile in My Shoes rally, which is a statewide effort to help promote awareness of mental health and also give people we serve a platform for their voices to be heard. So despite the nasty weather in the morning, it poured down rain as we were trying to set up, but the clouds parted and the sun came out a little bit, it got warm, and we had a pretty good turnout. We had, I think, probably 2,500 people come. We had a few legislators come out and speak to us, but because of the night before they were in session until 2:30 or so in the morning, there weren't a lot of them attending this year, but hopefully next year we'll get more. And then, as some of you have, we also passed out buttons with different statements on them to all our staff. And we asked them to wear them for the month of May to help promote Mental Health Awareness Month. So,
You can hear us coming, that's why I was holding, because my button's on, and so we make a lot of noise when we're walking through the building in May. So that's why I was grasping. One of the things, or some of the things I wanted to share with you in terms of outcomes of the initiatives and efforts, or the results of the work. So tomorrow, Malkaya and Dr. Reed will be interviewed here by Fox 2. The story is going to be about barriers to mental health for individuals who belong to minority groups. We are also holding the Suicide Prevention Awareness Forum on May 23rd. I know Annette shared some of this information with you. The Oakland Press is going to be doing a story about the event, and over the last 7 or 8 years, our outcomes and efforts in the community. Suzanne Weinert, who is also on my team, is working with Channel 4. During May, they do a phone bank where people can call in to talk about accessing mental health services. We always have a few people who go down to the station, they answered phones, but this year they asked if there was someone that they could interview with lived experiences. So Sherry Rushman will be interviewed by Channel 4, and she's going to talk about her hope workshops. And so we're excited. It's important to us that we put this multi-prong approach out into the community, hoping it sticks, and then we wait for the feedback and then do whatever we can to support our community partners in sharing this message with the ultimate goal of ensuring that, A, we are discussing stigma, B, that we're bringing awareness to the community that services are available and how they should access those services. Any questions?
Just a question on the proclamations. It seems that each month that is an awareness month, the proclamations are addressed with at least local governments during that month, and oftentimes it's at the end of the month. Is there any thought about doing it the month preceding? Sending out the proclamations, asking them to pass resolutions, accepting the proclamations in April, so that awareness is already started for May as opposed to the end of May.
Yeah, we have thought about that. Sometimes there's an overlap, and we don't want to overshadow what's taking place in April. And that's the same is true for March. So we do send out the requests in April. They actually start recognizing the proclamations in early May. So we send it out about 6 weeks. Sometimes, I think this year we send it out the end of March. But a lot of times they already have things on their council for April or for March, for example, being Developmental Disabilities Awareness Month. So we somewhat follow their lead, but we have had that conversation.
I've heard them say, oh, I wish we had known about this in April so that we could put things about it in our newsletter for May. And by time that passes, so oftentimes they have their council meetings, whatever Monday of the month, if it's the last Monday. I've remarked that they wish they knew ahead of time so they could feature it.
You know what we'll do? We'll send a survey to them. We'll asking when they would like to see that information. We'll look and see what the majority would like to see happen. Yeah. No, I appreciate that.
we have had a couple of townships have asked us, they've got the proclamation letter in April, and they've offered us either April or May to come and accept the proclamation. So some of them do it in April.
I would like to find out if I could get one of the resolutions sent to me as well. I'd like to introduce it to my community. And the social media campaign, I think, has been a great thing. I've seen it, actually. I've been on Facebook and seeing all the posts from, that are coming up with all the tidbits of information and likes and stuff. And I think that's a really effective way to get across to people, especially my age group and, and older. I think we're the ones that are on Facebook, right? I guess the younger kids are all on the Snapchats and all the other stuff, which I don't know anything about. And then the stigma is what my button here says, and I think I really appreciate that you guys are putting, these buttons out there and that information. I think stigma is probably a really big thing. It's what keeps people away from receiving mental health services because they don't want to come forth and talk about it. And I know Melchiah does a lot of work with that and what she does. So I appreciate what you all are doing. Thank you.
I want to say Debbie's really done an awesome job this year elevating our social media. It takes a lot of time and work, and we were able to build our staff again. We'd been down a few people, and in doing so, we focused and really put our attention toward reaching people through social media. We get a lot of feedback from young people, too, which is important. So I appreciate you noticing that work.
Facebook page, isn't that a closed group page?
The pages, our website is not, but it's not, it's private for making comments. So people cannot make comments on our page unless we approve them or see them first, but it is, you can access it wherever you are on Facebook.
So it's different Facebook pages?
You have to have, we have an organization page, and then we have actually our advocacy work group. So there are two pages associated with the organization. So the privacy settings are mostly because we have to be cognizant of the fact that sometimes people may post things they feel emotional about at the time, or they're not appropriate. So we have some monitoring in place for that.
Oh, I'm sorry. Judy?
I have to ask. I was just wondering if you ever had thought about, or maybe it's there and I haven't seen it, I would like a 12-month calendar like at the beginning of the year that just shows what's coming and, what kind of the different recognitions are that we're putting together. I'd like to see it kind of all at once so I kind of have a heads up too.
We have I call it the roadmap, the communications roadmap. So we build that every year. It outlines everything we're doing for the year by month, when we need to start. I'd be happy to share that with you.
So I wonder if maybe the communities would too, with, kind of along, maybe if along with our initial contact with the different cities and townships across the county, if we included a calendar so that they knew what was coming, maybe that would be the awareness direction.
Yeah, we can do that. We do, when we sit down at the beginning of the year, we schedule all of our events for 12 months in January. So we know where we're going to be, what we're going to be doing for the next 12 months. So it is already listed under our events calendar. But I could create, we have a document we use internally, it just lists. We can include that on our communications, our community outreach page. It's already developed. So we can do it both ways. They can look at it on our events calendar, and then we can keep just one list of dates and times. Not a problem.
Awareness of what's current and what's coming might be something to think about.
Absolutely, that's an easy one.
I'm sorry, the calendar, Christine, you're referring to, is it the one on the website?
The one that says events. So if you click on events, we have a couple calendars, and we have to keep them separate because training can be overwhelming, the number of trainings we do, and we don't want community outreach being confused by people in terms of training. So under training, there's a calendar, but under events separately, that does not include trainings. It only includes workshops, outreach activities, and any special events we have planned for the year. Events. It's right at the top when you click on it.
I've looked, and when I'm trying to find stuff for us, sometimes I go on the calendar, and I don't even see our stuff on there. I don't know what calendar I'm looking at, but
Get the public calendar, which is the events calendar. So the board meetings are listed under the events calendar as well. So I'll take a peek at it for you and look.
I need a tutorial.
I'm good with that.
I'll just put it out there like that. I need a tutorial because I'm looking at the wrong stuff.
All right.
Thank you.
Yep.
Anyway, I don't see any other questions, comments, and Debbie, I apologize for not introducing you. Anyway, thank you both very, very much. Thank you. The next item on our agenda is a presentation by Dr. Nicole Lazo, Case Management Overview.
Good afternoon.
Afternoon.
There has been a lot of discussion and changes to services and supports for people with the rollout of the service models. And so I was invited here this afternoon to speak specifically about targeted case management, kind of what that is, what that looks like in our system, and then any changes or impact we may have seen in terms of our implementation of value-based purchasing or the service models. So couple of points of overview that I thought might be pertinent to remind everyone of before we move forward is the rollout and kind of the timeline for the service model. So in fiscal year 16, which would have been October of 2015 through September of 2016, we started to look at the data and talk about service models and develop them out. In fiscal year 17, we really worked closely with our provider network to refine it, to finalize it, to make any infrastructure changes, development changes in terms of our electronic medical record, and it was implemented in fiscal year 18. So October 1 of 2018 is when all of this started. And then I just wanted to clarify as well this evening that targeted case management as a service does not even begin to reflect the total array of services and supports that's available in the service model. We're only focused on the one service this evening. So with that, what is targeted case management? So I won't bore you with all of the Medicaid language, but those bullet points that are up there do a decent job of starting to reflect what the case managers or supports coordinators throughout our network do. They advocate on behalf of people, certainly. They conduct assessments. They link and coordinate all of the services and supports, not just paid services and supports that a person may need to meet their goals. They also monitor the provision of those services and supports, making sure that people are happy, making sure that they feel like they're making progress, making sure that they're being delivered in the way that they're authorized, and they also then help with the development of the individualized plan of service. So certainly planning plays no small role in the delivery of targeted case management services. So taking a look at the number of people served. So in fiscal year 16, you can see about 8,800 people. FY17, close to 8,700, and in FY18, 8,211 individuals were served throughout the system. So that is an unduplicated count of people per each fiscal year. And if we look at where we're at so far this year, so I thought you might be interested to see it both by provider and then as a total in the network. So I wanted to note the focus on the unduplicated count of people. So if we look at the annual trends, if that trend continues, we can expect to serve around 8,000 individuals this year in targeted case management. But when you would look at our total month over month so far in fiscal year 19, you'd see that there's about 6,000 plus-ish people served every month. So we know that new people come into the system, people hopefully meet their goals and feel like they can be supported by community resources. So, you look at a year-end total that looks slightly different than your month over month, and people kind of moving in and out of services would be the reason behind that number looking a little different. So looking at historical data, this data was pulled when we first started to think about service models and engaged the national consultant to come in and work with the entire team to develop that out. And part of that guidance was pull the data and look at where you're at right now. And so we did pull the data. We pulled it by service that were provided to people through the network. And so when we're talking specifically about targeted case management, we looked both at the number of months in any given year that people had received the service, and then we looked at that as a percentage of months served. So you can see in fiscal year 16, the data shows that the majority of people were seen for 6 months or less. So if we kind of annualize that out, you would say every other month or less that people were being seen by their case manager and receiving that list of services that we showed at the beginning. If we work that out as a percentage and kind of flip that from 6 or less to 7 or more, about 46% of people had received that service for 7 months then or more in fiscal year 16. That data really informed the service model development, both overall and as it specifically pertains to targeted case management. Our process that we used was really to run the data, discuss what we wanted to purchase, draft our ideas, and then share those drafts with the provider network to discuss, to troubleshoot, to refine it, to come up with whatever our final version would be. As we moved into our implementation, one of the things that we knew we wanted to focus in on was the idea that people receive a service very consistently, particularly targeted case management. Going back to that list of things that targeted case managers do, if they're really making sure that people are linked and coordinated and getting all of the services that are outlined or authorized in their plan, and making sure that people feel happy with those services and are moving toward their goals, in our mind, that would probably occur more months out of the year, not less. So part of that implementation, we met several times over many months, probably 4 to 5 months, and we collaboratively, I can't get that one out, developed an implementation plan. So I had referenced infrastructure changes. We did have to make changes to our electronic medical record. We had to make changes to the way people were aligned in that system, it was a heavy lift across the board. And so in order, one, to not put too much of a heavy lift out onto the case managers, and number two, because it did affect the way services were authorized in the healthcare record, we didn't want to alter or change people's plan cycle. So typically people will get an individualized plan and have that meeting minimally once a year, and then minimally 6 months in kind of have a check-in, a really formal deep dive to see how that's going. And we did not want to either accelerate or decelerate those dates based on our agenda. So by doing a 6-month implementation plan, it allowed for a really natural ebb and flow for some of those back-end paperwork type things to occur when someone's periodic review or IPOS was already naturally occurring. The changes began in April of 2017, and they concluded by the end of September that year, and that's what allowed us for the 10/1 of 18 start date for targeted case management. This chart is very exciting to me. This shows the change in the data after only 1 year of implementation. I will note I threw the FY17 data in there so you could see it. We wouldn't have expected to see an impact. We were still working out details and implementing everything. So really the big change would be from fiscal year 16 to fiscal year 18. And highlighting there. So you can see the number of people who received a service in all 12 months was 588 individuals in FY16, and by FY18 we were up to 886. And then I would encourage you just kind of looking at the total number of people who were served in 1 month of the year, 2 months of the year, and looking at the trend actually starts, you can visibly see that it starts to shift. And that is very noticeable when we look at it as a percentage. So essentially the providers were able to flip that change in a percentage in only 1 year, which is really astronomical, and it really speaks to all of the progress and the hard work that they put into ensuring that people were seen consistently and on a regular basis. So as we've grown and learned in terms of how we look at the data, we are moving into looking more at percentage or a utilization rate. And what this does is it allows us to see an unduplicated number of people who are authorized for a service in any given month, quarter, or year, and then how many people received that service in that month, quarter, or year. So again, going back to an unduplicated count and really taking a look at individualized data and making sure people are having their individualized needs met. Unfortunately, I don't have historical data available with this to share with you, but the data here is really pretty phenomenal and very impressive. So to walk you through it, that blue line, that authorization line, is the number of people served, and you can see it there by provider, in quarter 3 of fiscal year 18. So again, that's April 1st through June 30th. And then the orange line, or the people served, is the distinct number of people who received that service that month, which gives us a utilization rate stating that 93, 87, and 93% of individuals received the service that they were authorized for in that given month, which is an incredibly high utilization rate. And quite impressive. So if we look at our year-end results from fiscal year 18, those are even better. So as a system, as a whole, we had a 96% utilization rate for all of fiscal year 18, which again just speaks to all of the hard work and the dedication that our provider network and the case managers themselves actually put into making sure people knew when their appointments were, meeting people where they were at, and making sure that those services were delivered consistently throughout the year. So the impact for people, consistency in the provision of targeted case management supports and service, and hopefully increased support of person-centered planning in the golden thread. So there again, the more often that case manager is checking in, are you getting these services? Are your supports, your friends, your allies helping in the way that they said they would, helping the person to troubleshoot anything that might not be going kind of as planned, lends itself to better overall progress, goal achievement, and living the life that that person wants to live for themselves. Certainly there was a large impact for our provider network, and I had broken this kind of by policy and funding because they had both to contend with as part of that build-out year. So certainly shifting to a case rate-based payment. So payment coming once we know that one of those services kind of in that service bundle had been provided was a big shift. Conversely, and hopefully in a way that was very positive, they had an ability to achieve a 2% profit. It wasn't just cost settled at the end of the year. From a policy standpoint, there was certainly a focus on staff productivity, because if we were valuing people being seen very consistently, being seen hopefully every month as much as possible, then the providers really had to take a look at making sure that case managers and the number of people they support are reasonable, that they're able to achieve that, and that's part of their business model that we don't dictate here. So they had to kind of gather their forces internally, take a look, and decide how they wanted to roll that out. And then I did notice just support to achieve incentives. So while we're not talking about the service model as a whole here, in the targeted case management service model, a lot of the documentation and the provision of service certainly rests on the shoulders of those case managers. And so there was a lot of support both from us and then in terms of what the providers had to figure out as part of their business model, and to support those case managers to help them achieve incentives, which then is additional funding dollars that they get above and beyond the ability to achieve that 2% profit. That should, by design, hopefully also improve the lives of the people that they're supporting. Oh, and are there questions?
So much. It sounds like you've done a terrific job with helping the providers and the case managers. I was just wondering, can you give us an idea of how many case managers there are in 2018 versus 2017? Was there an increase, just decrease, just an approximate? Because we have the numbers that you've served, but I'm just wondering, how big is their load?
Unfortunately, I do not have that at my fingertips, but we can certainly get that to you. Thanks.
Do you have a sense, as this model has evolved and the consistency has really remarkably increased, that there's more satisfaction on the part of the case managers, that they feel like they're having more impact on the folks that are a part of their responsibility?
No, I don't know. Unfortunately, through our role here, we don't get a lot of face time with individual case managers to have those discussions. Typically, when we're meeting with the administration from all of the core provider agencies. So it's an intriguing question, and I guess I would like to know the answer to that myself.
Figure out a way to get that? I'd certainly be interested, because I think that it seems that with this consistency, the knowledge of the individual has to be much increased. And I think that the ability to plug in the proper supports or to punch when needed if there are changes would be much more clear, because the relationship seems like it would be a little bit more intense, perhaps. So, but I'd be very interested in knowing if from the case manager side of things, if there was an increase in their ability to impact, and if that increases their satisfaction overall as well, besides just the data showing us that the consistency and the contacts are very steady and very encouraging. So if we could find something like that out, I'd be fascinated to know that, should the opportunity present itself. Thanks.
I don't know if you'd be able to put up slide 7 again. So I know, Malkiah, you're giving me a look, and I just want to be proactive here and say, we have heard, mostly from Malkiah speaking on behalf of case managers, that this has decreased their flexibility, and the intent of pay for service is to increase consistency in meeting the authorization. So if we take a look at slide 7.
Right one?
No, I'm sorry. The graph. It's the, yes. And if you look, the majority of people with authorizations, the authorization would be, the intent is once a month that they would receive targeted case management minimally, once a month contact. Now, when you look at this graph, particularly if you're looking at the gray line would show for fiscal year 18 how many people actually got the once a month service. So if you go to the left, you see the gray line for people who got it once, twice, 3 times, 4 times, 5 times. And you see where you've got the years, how often we're getting that low utilization. Despite this service intended to be a very frequent, regular service, people were getting a low amount of targeted case management service despite what the authorization said. If you look towards the right side of this graph, and particularly look at the gray for fiscal year 18, you'll see after we changed the payment model, suddenly people are getting 9, 10, 11, and 12 contacts per year. So I guess we've had conversations about how this feels for the workers in the field, but the intent is we were paying the dollars for this to the core providers, but people weren't, it was a lump sum capitated funding where people could use their discretion totally. But if indeed the authorization said 12 per month and people were getting 1, 2, if you look at where the orange line is for once per month in fiscal year 17, the majority of people were getting seen once per year, I'm saying month, I'm sorry, once per year for case management when they were supposed to get 12. The data shows us the trending was going the wrong way, and that people weren't getting that routine contact with their social worker. We don't want to make assumptions about that, but we certainly didn't want to be an entity that only paid for psychiatric medications for folks, and we weren't doing the things to help implement the person-centered plan. So while I have heard from members of the board and some from the community that this has been a stressful transition, our priority has always been and will always be the people we serve. And if indeed their IPOS and their plan of service and their individual goals and objectives led somebody to say that they're supposed to get 12 contacts a month, we had to put a payment methodology in place to say, if it's said 12 times a month, we want to see them get in contact 12 times a month. If their needs are less, I'm sorry, I keep saying that wrong. Gosh, I'm trying to clarify, I'm making it more confusing, aren't I? If it's supposed to be 12 times a year, we wanted them to be seen 12 times a year. So I hope that's why, and when I asked Nicole to do this data. And it's a tough conversation to have because we're all shifting to this new model. But that's what pay-for-service, values-based payment options are about, saying we want to make sure the way that we are funding services leads to the best outcomes for folks and people that we serve. So that's why we've gone in this direction, and thus far, the data shows us we're going in the right direction. I know you're
Looking at me, so.
I know you've
I
been
know.
frustrated by this, so.
I am. And what this is showing is good, but what it's not showing is turnover. And I didn't even want to talk about that. I want to talk about that, but it's a reality. The Medicaid health plans pay more money than we can pay for case management. So it's hard to
Accurate.
hold people.
No doubt, that's accurate.
To this standard, and I know we're getting the outcomes, but if we're losing people, I'm not saying that this is causing us to lose people, but it's something that I don't hear us discussing. And we talked about this at the fall conference because I attended a workshop specifically talking about turnover. And one job well, but also take care of the people that are doing the job so that they can do the job well. And that's the only point that I'm trying to make because that's the part that I see is missing. I know we have to take care of the people that we serve, but if you're not taking care of the people that serve the people, and that's what I see. And I'm not, and everybody know I work for CNS, but it's not just happening at CNS. I'm sorry. It's not just happening at CNS.
When we implemented this new payment model, we did put in the risk language. So as we rolled this out to core providers, we did not want anyone losing money to make this change. And we did utilize risk reserves to make sure we made the providers healthy in this change. I wish I had an answer for the health plans recruiting. It's happening every level, including
And
our
the
own staff.
hospitals.
So I don't have an answer for that one.
If we don't address it, I don't know how we're going to be able to keep good qualified staff providing the service that we need to provide to the people we serve. And I don't know the answer. I'm not pretending that I do. But I know if a person is not happy in their employment, even though they're doing what they're doing, how can they provide good service to the people if they're not happy, if they're not, and I don't even know if I'm making sense right now, but when a person is frustrated, sometimes the people that are being served get caught up in that. So I don't know what the answer is, but I know everybody's looking at me, and I was determined not to say anything.
Sorry, I know you asked for this presentation.
did.
And we did want committee whole meetings to be more of a dialogue, so I'm sorry, I didn't mean to call that attention to you. And I know that you have felt.
You weren't the only one looking. So
Oh, okay,
that's
I'm
what-
sorry.
No,
I wanted to tell you
I didn't say you were
that.
looking, Steve. I didn't say Steve was looking too.
Steve, quit looking at my guy.
Okay.
All right.
Just for the newcomers, we all know that look.
Yes. And you know what? My wheels are turning, and I'm sitting here thinking, should I say anything or should I let it go? And I was going to let it go.
I apologize, I shouldn't have called you out like that.
No.
I was trying
I
to
was going to let
explain.
it go, but because it's not just targeted case management. It's also with the peers.
We're
If
gonna
it was
have
just
the
one
same
area-
dialogue with peers, yes,
Right.
I know.
And
Yep.
if it was just in one area, I think it would be easy to overlook. But I've talked to people. I talked to one person in particular that used to be a peer who's now working as a gas station manager. We're losing good people, good quality people, because we can't pay them enough to do the job. And the ones that are there, so I can't speak for all of them. But I know that there's a level of frustration, and I don't know what to say that's going to make a difference. So that's where I'm at with that. And
Right.
everybody can keep looking at me.
No, and there's an underfunding, I know, and
I know.
there is an underfunding problem, I
is.
know.
It
Okay,
is.
I hear you.
Okay, thank you.
That funding problem is facing everyone in this industry, and afford to take care of yourself and being asked to take care of other people. I don't know the answer, and I'm not sure that anybody, I think the state should be the ones to provide the answer and the solution.
They said they wanted to start attending our board meetings, and I said, you can attend, but when you do, I hope you're going to give a presentation to the board, because we would like them to sit right there and talk about it. So we'll continue to have that ask.
Seeing that, we're going to move it. Thank you very much, Doctor. Appreciate that. Item for discussion is Section 928. Anya?
I don't know how to work the technology. Okay, thank you. Okay, you do not actually have a handout for the section 928, and I have to be very careful because 298 and 928 are two very different things. So the point of talking to you about section 928 is just informational. It's something that's going on in contract negotiations actually with the CMHs. For those of you who are new, we are both a CMH and a PIHP. So when we have contract negotiations with the department, it is either as one or the other, they're not combined. And so they're talking about this particular section that is in boilerplate language, I believe, and it's section 928. And what it is it requires us as a CMH to contribute to the department a certain dollar amount on a quarterly basis, which the state then uses to draw down additional Medicaid. So for every federal dollar the state gets, they have to put up a certain percentage of that money. So for example, it's called the FMAP. It's the federal matching something. I should have looked up the acronym before I came up here. But it just requires the state to put up a proportion of each federal dollar with state revenue. And so for every dollar they give us, they have to come up with general funds to cover their portion. So several years back, what happened is the state had a shortage of general funds and convinced the CMHs to send local money up on a quarterly basis, which helped them draw down additional Medicaid. So that went on for as long as I can remember, and I've been here going on 20 years now. And eventually, people started, as budgets seemed to get a little bit tighter, local money was obviously more of a hot commodity because it has the least restrictions. People started to question having to do that, and it wasn't actually written anywhere in our contract. So the department went ahead and put it in our contract. It wasn't really negotiated, it was just kind of snuck right in there in our CMH contract. And now, again, with the continuing budget issues for all of the CMHs, people are starting to push back again about having to contribute this local money to the state to draw down additional Medicaid funds, when technically that is a state requirement, not a CMH requirement. So it's getting a little traction now. So what that means for us is we contribute every year about $2.4 million of our local money that we get from the county to the state to draw down additional Medicaid. In total, for the whole state, between what everyone contributes, it pulls down an additional $75 million of Medicaid. So ours is a small portion of that, but it does add up over the entire state. And if we didn't have to do that anymore, we would then be able to utilize that local money in Oakland County instead of sending it up to MDHHS to draw down Medicaid money. One of my concerns initially when this was brought up was that if this were to somehow change how much the state was going to push down to us in our rates, then I would have concerns, only because we do get much more back than we contribute. That is not the case. So the state will have to come up with the additional general fund revenue to make sure they can fund the actuarially sound rates, yes, in quotes, that are provided to the PIHPs. So
This is really just a heads up, should anyone mention this to you or contact you about it. We are in support of it, and certainly would like to keep that $2.4 million of local money in order to be able to utilize it within Oakland County. Does anybody have any questions on that? That's kind of a very high-level overview of that section.
Talk on this in the past that the state was taking the local money from all the CMHs, and then not all of it was actually being used to draw down Medicaid funds, and that therefore it should be returned to us, and then it never happened. Am I correct in that?
Well, what it does is just essentially reduce their liability for general fund dollars for the total amount they have to put up for the Medicaid revenue. Because they're giving us less Medicaid revenue in general, that therefore reduces their general fund liability, and then they just take all this local money and reduce it further. So, yes and no. I mean, to some degree, it's just subtracting what they have to provide as general fund revenue to match the Medicaid revenue that they push out.
Across the state, particularly the CMHs or the PIHPs that have multi-county CMHs, this 928 is a big advocacy push. Because it's so close to 298, I thought, I just asked Adia, let's at least let people know the push behind it means keep the local dollars for local spending. And if it does win in advocacy, we'd have an extra $2.4 million, which we would gladly take. So we're just putting it on everyone's radar. So if you hear 928, it's about local money going to the state to match federal dollars.
Sure, I understand. The local match dollars are the most flexible dollars we have, too. So if we were able to keep more of the local money local, we would have more flexibility in how we could use those dollars?
Yes. So local money is essentially the amount we get from the county every year. It's about $9.6 million, has been since we separated from the county. And it does have the least restrictions related to our different fund sources. So it is kind of the gold standard of fund sources, just because we can do with it what we need to and kind of fill gaps with it. For us as a PIHP, it's something that we get because we are a standalone. We get a little more flexibility with fund sources than other, and I'll talk about that in addition in a minute. Because CMHs and other PIHPs don't necessarily get to play with it like we can, because they would have to get their CMH to contribute to their PIHP, whereas we are one and the same, can have that flexibility. So definitely it's the fund source we're most protective of and use last, just because it has the least restrictions. Lots about fund sources next. So I'll go ahead and move on if no one has any additional questions. So you have the PowerPoint in front of you. And for those of you that are new, this is going to kind of be jumping in the middle of some fund source information from fiscal year 18. It's part of our fund source information. It's not an all-inclusive fund source discussion. It's really specific to how we handled fiscal year 18. And I want to just make sure to make a point, because we did have a board member ask a question. This is not in any way, shape, or form about our audit. Our audit is still going on. We expect them to come and be able to present in June. And this is really just because this year we handled slightly differently than we had in past years. So I just wanted to make sure you all as the board understood how we covered the deficit in fiscal year 18, because we did have a pretty material deficit. And I wanted to make sure you understood, again, with fund sources, kind of how we're able to juggle a few things here and there in order to cover that deficit. And this is what we did to put that in pictures so it was easily understandable. So we reviewed this with some of the board members a few weeks ago, and then decided to bring it here just so that you all had the information, and then any of the public that wanted to understand kind of how we dealt with fund sources at year end. This is the coverage of that. So if you turn to the first page, and I'm gonna see, this is why I don't do this while I present. Okay. So this first page is intended to represent how money comes in and basically what it turns into when we get it in. So we have a few different primary fund sources. So this document shows you that we have Medicaid that comes in with the tag of behavioral health. We have Medicaid that comes in that's labeled as autism, and we have Medicaid that comes in that's labeled as substance use. Once we get it, it loses that label, other than the fact that it is still Medicaid. We also have Healthy Michigan that comes in. Same concept with Healthy Michigan. When it comes in, it's identified as either behavioral health or substance use, but once we get it in-house, it's actually just Healthy Michigan. In addition to that, we have it's a local liquor and convention tax that we get. It's called Pa2 revenue. So that's essentially tax revenue and convention tax from Cobo Hall that we get in order to pay for prevention and services for substance use disorders. So what this slide is intending to show you is that really these fund sources come in with a what's the word I'm looking for? Population designation, but once they get here, they lose that population designation for the most part, other than to say they still are Medicaid or Healthy Michigan or PA2 is specific to substance use. Then when we do reporting at year end, what we have to do is identify expenses. So when we do expenses, we look at things that are more so based on population. So we have behavioral health expenses. That could be Medicaid, they could be Healthy Michigan, they could be autism, they could be any number of different populations, but they're specific to, we have a group of populations that is considered behavioral health, we have a group of populations that is considered substance use, and then we have non-substance use expenses as well. So when we look at expenses, it's typically based on population, more so than it's based on fund source, because we have multiple fund sources that cover each population. So just because I receive, let's say, behavioral health services, I may be funded by Medicaid or I may be funded by Healthy Michigan. But my population designates that I'm in the behavioral health bucket. Versus substance use, I could be any number of the different substance use populations being Healthy Michigan or Medicaid, or I could be not either one of those fund sources, but I'm still behavioral health. So if I have no insurance, I might still qualify for behavioral health, substance use services, but I'm still in the substance use population. I'm going to stop before I move on that one and make sure you all understand that. Does that make sense before I move on? That when we look at expenses, it's really more about the population and less about the fund source. So then when we talk about revenue that comes in, it has different restrictions, much like we were just talking. So Medicaid revenue can be used only on very specific populations and services. So on the left there, you see the Medicaid revenue, and you see the two arrows that allow us to use Medicaid revenue on Medicaid-eligible behavioral health services and Medicaid-eligible substance use services. We have Healthy Michigan revenue that we can use on eligible Healthy Michigan behavioral health services and Healthy Michigan substance use services. So that's the intention of those arrows there, is to show you what we're allowed to use those different fund sources to cover. And then we have PA2 revenue. And if you remember PA2 revenue, the restrictions on PA2 revenue is that it has to be used for service or prevention. It cannot be used for administration. Otherwise, it's pretty flexible. So when we run out of Medicaid or Healthy Michigan, we can use PA2. We just cannot use it for administration. So that's why when we talk about local money, which is an entirely separate fund source, it has the least restrictions. We don't have all of these. You can use it for one population or one specific set of services or the other. It's completely flexible in what we can use it for across populations. So many of you know that we had in fiscal year 18, we had roughly, the last budget amendment had a projected Medicaid loss of about $20 million. We started the fiscal year at about $25 million planned deficit. We ended the year with a budget amendment that had it at about $20 million. Our bottom line numbers for Medicaid specifically were roughly $19 million. So we were less than $1 million away from what we were budgeted as far as the Medicaid loss went. So what we did in fiscal year 18 was we took all of the Medicaid revenue and all of the Healthy Michigan revenue and used it solely for behavioral health services. So again, if you remember, some of it came in with a substance use designation for both Healthy Michigan and Medicaid, but when it comes in, it loses its population designation. So we chose to use all of it for behavioral health. We chose to do that because we have a pretty hefty PA2 balance. We had, at the beginning of last fiscal year, I believe we had about 20 million of PA2 in reserves. So what we chose to do, and we got approval from the Substance Use Oversight Policy Board, was to use a portion of that reserve amount to cover substance use expenses. So we were able to take the Medicaid and Healthy Michigan substance use expenses, and we are allowed to use PA2 revenue because you're allowed to use it for prevention and services, just not administration. So we utilize all of the Medicaid and Healthy Michigan revenue on the behavioral health services. We used PA2 revenue to cover all SUD Medicaid and Healthy Michigan services. Does that make sense before I move on? I know this starts to get pretty complicated. That's why we were attempting the buckets, Judy calls them, I think. You know, it's fairly complicated, so the visual is an attempt to try to explain it in a little better way. So the end result is essentially we had fiscal year 18 revenue and expenses. Medicaid revenue was about $233 million. Healthy Michigan revenue was about $32 million, for a total of about $265 million. We had Medicaid expenses of $251 and Healthy Michigan expenses of $34 million. So again, that's that total deficit I talked about of about $19.8 million. So again, all we did was take all of the Medicaid and Healthy Michigan and utilize it on the behavioral health services, and we use PA2 money to cover SUD services. So it's a shift in what we've done before, and like I said, we did have to go to the Oversight Policy Board to get approval to use that PA2 reserve. There's still about $15 million in that PA2 reserve. So we by no means used it up or anything like that, but it did help support the fiscal year 18 substance use services. And going forward, certainly using reserves is not a long-term solution, so we're currently looking at ways to continue to reduce expenses and working with the department to continually work on funding and appropriate geographical factors.
Said we also met with the state to review this plan of using these buckets and these reserves before we implemented it.
So that's a lot of information in a very summarized manner. I can also, let me go one next slide. So this kind of tells you how we utilized the deficit in total. So you can see the Medicaid reserves utilized. So we used roughly $9 million of Medicaid reserves, leaving about $3 million in there. We used about $5.5 million of PA2, and then the excess from fiscal year 18 revenue as well. So that totaled the $19.8 million.
Because Jonathan couldn't be here, he asked questions. So in your email, when you get home tonight, like the balance of the reserves and everything are in your email summarizing what Anya just said.
Out this afternoon, so if you haven't seen them, Jonathan asked a few questions, so those are all in writing in your email. Well, they didn't give us any more money.
Conversation.
So it was really just conversation, really to understand from their perspective. You know, having been through this several years over now, we have a tendency to see swings in Medicaid revenue that go from one side of the state to the other, or those types of things. So what we don't want to do is make material changes if we're looking at new methodology in fiscal year 20, which we are. So what we went really looking for was an understanding of, was this, if this is the reality of the Medicaid revenue we have to work with, we just need to know that, and then we'll make adjustments to live within that. They did give us some indication that they do expect the new methodology to give us to give geographic factors a better way to predict cost. So in my head, that means understanding that the population served in Oakland County has has different needs than across the state. Very roundabout way of saying I think that this redistribution will be good for us. Well, unfortunately, in the last adjustment, the Tri-County took a pretty hard hit in total. So Wayne and Macomb did as well. I will tell you that for fiscal year 19, currently there's 9 of 10 PIHPs that are projecting material losses. And then I wouldn't expect 20 to be much better. They're making a couple of other changes related to how they're paying retro eligibility that should help. And I do actually expect there to be some shift in they can't, it doesn't look good for them either when you have 9 of 10 PIHPs that are having material deficits multiple years in a row. Those aren't actuarially sound if that's happening, and that's not a misuse of money when it's 9 of 10. So to some degree, they have to deal with this. So they can't have a system that is completely unable to sustain when they have thousands and thousands of people. So I do expect to see changes, and what I think both I heard and Annette and Kathleen heard when we were there is that they're working on trying to make some adjustments to fix it.
They didn't write us a check, though, like we were hoping.
No, I would have liked that. I would have liked to.
The only reason I mentioned Wayne, because they're loaded with money.
Their budget is much bigger than ours. However, they serve a lot more people than we do.
They get a lot more money.
I wouldn't necessarily say they do. Their budgets are about 600 million. They do, however, serve a lot more people than we do. They serve a significantly larger population than we do. They did also lose $32 million last year and are projected to do so again this year. So they're in the same situation in that they're continually losing money as well. Macomb's in the exact same situation. And like I said, now in 19, 9 of 10 PIHPs have material losses. There's only 1 that does not. Every time.
Thank you very much for this. What I think is a very understandable graphic aspect of how our money comes in and how we have some ability to use it in the way that it needs to be used to address our needs. I'm a little bit bothered when you say that the state is looking at ways to fix, because is it a fix or is it a dent in addressing it, or are we still potentially looking at some tough decisions down the road that even should we get additional funding, we still are going to have to find very creative ways to make the budget work for us?
Also, as far as fiscal year 20 goes, until we see you've heard me say this before, until we see the rates, it's very hard for me to even guess at what it will be. I'm hopeful that what I saw in the appropriations thus far looks like they're higher. They do look higher. If that all gets pushed out, that would have an impact. But again, that whole budgeting process is not done yet. So what we see in the House budget and the DHHS budget, all of those things get changed, and there's a lot of politics involved that don't necessarily always tie to the needs of the people we're serving. So I'm hopeful that the appropriations will continue to look better than they did last year, and that in addition to that the geographic factor adjustments will help us. I hesitate to say that it's going to fix everything because I don't think it will. I think for us, we are definitely moving, and the department did say this, we're doing all the right things. We're continually looking at our administration, we're continually looking at consistency in rates and services across our network. So you're doing all the right things. That's why we went there and said, we're doing all of what we think you want us to do. So you got to tell us what gives. Either this is just the amount and we have to make some changes, or we need to know that there's something else going to happen here. I got the impression, and I think Annette and Kathleen would agree, that we should have some changes for fiscal year 20 for sure. I can't put that in writing or anything because it's not that easy.
Around much too long to
Yeah.
think that somehow or another that magical moment will actually occur, because not only when they talk about rates, it's when they advise us of what those rates are. The timing of it sometimes doesn't really help
Yeah.
our budgeting at all.
Yeah, and I remember years of getting rates on September 30th. And that's certainly, and I did express that concern to them, and that as a finance person, it's very hard for me to manage a budget when I don't even know what it is for the rest of the fiscal year, quite honestly. It's kind of a shot in the dark with what we're getting, what we're seeing with the eligibility trends and things like that. And then to not know, have any idea what fiscal year 20 looks like, especially when the people we're serving does not change that materially between one year and the other than to say things get more expensive. So it's a very difficult way to manage a budget. It's certainly not how most businesses would ever want to manage a budget. So we do the best we can to monitor and make adjustments as needed, and we'll continue to do that when we do go to start budgeting for fiscal year 20. My hope is June. They said June. Fingers crossed. Yeah.
A little hard to have confidence
know.
in their deadlines. They don't often meet them.
I'd like to make a comment. Certainly, the department tried to be as hopeful as they could in their conversation with us, short of giving us any definitives around the budget. They do expect us to live within a budget. One would certainly expect that, yet I want to make sure everybody understands we do have a history of soft landing and trying to make this work with the money that we have available. Nonetheless, we expect a positive move. If that doesn't happen, then we'll have to take a look over the years on how to live within our budget and the revenue streams that we do have. So we're hopeful, and with the service models moving in the direction that they're moving, we expect to see better outcomes and more efficient use of the funding that we have.
I appreciate the presentation and the graphs here, the buckets as you call them. It's very easy to understand. So you mentioned that we went into our reserves to pay out for some of the deficit that we had. Do we have a fund balance that we're required to have by the state?
So we don't have a fund balance we're required to have. We are allowed to carry reserves of up to 7.5% of revenue in a fiscal year. Right now, and that being said, that's related to Medicaid and Healthy Michigan. So MDHHS doesn't have a say in what we have for local. So we have a local fund balance as well. We keep them all pretty separate, but right now our Medicaid fund balance after last year is $3 million. And then, as I mentioned, our PA2 fund balance is now at about $15 million. And then we also have our local fund balance, which is about $26 million.
What is that percentage-wise?
Percentage of which fund source?
Well, any of the three. So you said the PA2, the
PA2
local.
PA2 is at about $15 million is our current fund balance, and our annual revenue right now is about 4.5. So it's a considerable fund balance for that particular fund source. Local, we get $9.6 million a year, and our fund balance is about $26 million. And then, Medicaid revenue, if you were to combine Medicaid and Healthy Michigan, where it was about $265 million, I believe, and we have only about $3 million left. So typically, we would like to have a fund balance far greater than that, but the last couple of years, we've had to use it in order to smooth out the struggles we've had with Medicaid funding over the last few years.
Am I correct? We knew that we deliberately ran a deficit. We did this to do a soft landing for the new funding models.
Yeah, so it was our intention. This was budgeted. So like I said, we started fiscal year 18 with a roughly $25 million projected Medicaid loss. We ended the year with about a $19 million loss. So it was planned. And again, it's about managing this business is really about funding services for people, not necessarily keeping money in the bank. So we manage that. By all means, we never want to use it all. That's not the goal either, because it is kind of our safety net. But certainly, it is not our intention to just have it sit there just to sit there. That's not what it's for. That's not why we're allowed, to have reserves. So.
Excuse me. The meeting that we had was very worthwhile, and I think Anya did a great job in explaining it. Pardon my voice. As a matter of fact, that meeting was the result of many concerns that board members had. And I think Judy was there was a meeting that only 3 board members attended. It was Judy, myself, and Malkaya. And it was open to the public, and nobody showed up, but you were certainly prepared to have open dialogue, and we did. And Judy is the one that recommended that we put these so-called buckets in with all the arrows that pointed to where the money is going to. And at the end of the meeting, we all suggested that this would be a very interesting topic to have an open session, whether it be a study session or at a board meeting. The pictures tell a big story, and that's what you've done. It is what it is, but I think I now understand the juggling. That's your word. The juggling
Within
act.
all the rules.
Well, of course. Yeah, as a matter of fact.
An inch of the rules.
In fact, my notes stated that. So I now understand the juggling act that we have to go through in order to make the numbers work. It is not an easy juggling act. It's a rather complicated juggling act, and you can't relate it to most businesses because there's a lot of unknowns and unpredictables that you just can't use. And so I think Anya and her staff did a good job in their presentation, and you even carried it forward and improved upon the presentation for this meeting here. The big question is going to be the reserves. And that's an unknown that stated it was a good idea, and you're going to work to develop something, even if it's a side drawer program or plan, which is good because we are going to be dipping into our reserves while they're there, but when they're not there, that's when Plan B better be brought forward and well thought of. So we are working in a good direction, much better than most of us thought. And I'll be the one to say most of us was mostly me. But I appreciate the fact that you drew these lines. I appreciate the meetings that we've had. I understand how the money comes in, and that's another issue that staff had to deal with because it comes in one lump sum and at the most misappropriate time of the month.
Yeah, this is true as well.
But nonetheless, if anybody has any other questions, Steve?
Comment. As mentioned, there wasn't really great attendance at the meeting, and I'll tell you the reason I didn't come is the first that I ever heard you were having this financial discussion was an email I got from Victoria that was reminding us if we didn't remember that and I never heard of it before, and it was I already had places to be that I couldn't attend it. Maybe about 10 days before the meeting was the first I'd ever even heard of it, and I definitely would have attended it. So
But we can certainly make sure in future that it's communicated differently.
The meeting was on April 29th, so it was discussed, and I'd have to look back. It was discussed just in one of these forums. I believe it was Judy who said, I want to remind everyone that we have the meeting coming up where we'll be doing a deep dive on finances. I can't remember if it was committee of the whole or the board meeting. I can't remember. It was posted for the public. Victoria sent out emails. Jonathan raised the question that he too missed the date, and I went back and looked in my weekly updates that I sent to the board. I did put in one, and it was the week before, just saying, we'll talk more about this when we meet next week to go into finances. But nonetheless, I will say, when we were consulting, we knew we wanted Sid, Malkaya, and Judy as our board chairs and the committee chairs to be there. We didn't consult the entire board on availability. And it was a matter of, we wanted to pick a date that we knew at least the people leading the committees could be there. We acknowledge that we need to give more advance notice when planning a deep dive meeting on finances. So we will do that in the future because that was shared with us by Jonathan as well. So obviously, if Steve too felt there was a little lack of communication, then I'm going to own that. And yeah, we will do better in the future. So I apologize for those who didn't know enough in advance to plan to be there.
So, what up on your report, or
All set, unless you guys have more questions.
I wanted to make sure we thank Claudia because she also helped with the buckets and the arrows.
So, I will tell you what I handed her was me with my daughter's colored pencils with the buckets and the arrows, and she translated it into that. So I will tell you, my version was not pretty.
Well done. Thank
Takes
you
a
very
village.
much.
It does.
next time, could you draw buckets with cash in it?
Yeah. We need
That
green
would solve
buckets.
our problems.
Green buckets.
Okay. Thank
Well, this leads to our last opportunity for public comment. Board comments. And I'd like to run through the board and whoever else would like to make comments. So starting.
Sure. So I appreciate the opportunity to serve on this board once again. Just trying to get up to speed as best I can on the information that was presented today, and the information that we received at our orientation last week has been very helpful. One of the things that I had an opportunity to do when I served on the board previously was I was on the, and I'm not sure what the dynamic of the committees were, and I think we have the committee of the whole previously had the business operations, and then we had public policy. So I am interested in business operations again. I served as vice chair on that years ago when I was on the board, so it's something that I look forward to doing. I appreciate the presentation, the information that was presented today. Very easy to follow and good, so thank you for making me feel welcome.
That's your cue.
That's
your cue.
Yeah, well, thank you
Board
also.
comments, the musical.
Right. I agree with John, too. Our orientation was really helpful, and this was really important to learn about. I do have a couple comments about the finances, if I might say. So, the PHIPs, the other PHIPs, and really anyone who deals in government, which is not like a business, or a nonprofit organization, often the funding you don't know until really the last minute. So what some financial and CFOs do is there's literally two separate budgets that are created. One that's created that's an as-is, expecting nothing to change, because you don't know what's going to happen, but at least you have a plan. And then the other budget is, it sounds like, which is great, hopefully, it sounds like there's going to be a positive and a possibility of new funding for next year. And then the other thing, I just want to make a comment about reserves. I think that in general, it sounds like, which is really fiscally responsible, we have these reserves, which is wonderful to be able to dip into it if we need to. And it sounds like, we need to. Appropriate amount is, or what is fiscally responsible for an agency this size to have in reserves, whether it's 7% or 10% or 3 months of what you pay for administration. So, some of these things might be able to help for financing, but it was great to have this, to be able to look at it and really understand, where we're headed. And then the only other thing I wanted to talk a little bit about was case management. I don't know my colleague's name. So, what Micaiah brought up was really important, because obviously you can't help everybody in the community unless those case managers are helping. Talking about how we can help what it is we do as a committee to help those case managers help our.
Picking up on the last comments about our case managers, I think what will be helpful is a direct statement or a direct recommendation to the case managers as to what they can do to take care of themselves. In many organizations, regardless of what it is, or educational organizations, there's a directive about taking care of yourself, initiating some kind of program for yourself or whatever. So I think that would be helpful to have something identifiable that the person is actually working on to take care of themselves, not only the people they serve, but also themselves too. And there's quite a wide range of things they could do, everything from skydiving to, educational things. So I think it's very important. I also want to compliment our presenters. As the years have gone by, our programs have increased, have expanded exponentially. And it's amazing how complicated they've become and how wide range they've become. And I just want to encourage our new board members to be patient with yourself as you get caught up to snuff, so to say, because there's a lot to absorb here. And the graphics just continue to get better and better. So.
I'm going to jump ahead. First of all, in your packet today was an item that comes from the Board Association that talks about the responsibilities of a board member. It was part of the packet for the orientation for our new members. And when I was reviewing the material that I wanted to include in that orientation, I came across this and kind of reappreciated what it has to say. So I would really encourage everybody to take a look at it. It gives our flexibility and it also provides our limits. So I think that having a reminder of what our roles and responsibilities truly are is always a good refresher. So from that point of view, I appreciate that was in our packet today. I'm going to be sending out an email next weekend that's going to give a little bit of a heads up about a couple items that are going to be on the board agenda. And one is we need delegates for the spring conference in June. For people who are attending, if they would think about being a delegate. It's a little bit awkward because it's local and because people are not staying overnight. The voting occurs the night before the actual beginning of the conference. So it requires a little bit extra commitment that I'd like you to consider if you are attending the conference, if you can make that extra step. And that tells me that we need 4 delegates. I haven't remembered in the past that we need, with Annette and 4 delegates. So that's our commitment, and I just want you to keep that one in mind. Also, I think that I want to remind you that we had some recommendations from the University of Delaware and our workshop that evening regarding strengthening the collaborative aspects of the leadership on the board, and of which all are leaders. It is not meant to separate out officers or the like. Everybody on this board is a leader, and the leadership team within the organization. And I think we will be taking some steps next month at the Committee of the Whole to address some of what was identified as positive steps forward in being more collaborative and having the board be involved more strategically maybe than we've been in the past. The other thing is that we also had some guidance from the consultants from the University of Delaware regarding public comment. And I would very much like to have a discussion at our next meeting regarding if we want to set any new parameters. And that'll be the information, some background information will come to you from me this weekend in my email. Also, I will be providing a brief update, but I will attach documents to my email regarding the activities of the evaluation committee for the CEO, where we are and what the timeline will be for that, and that'll come in that email this weekend, and we can discuss it more next Tuesday night if there are any questions. So that's about it for me. That's too much probably, but that's about it.
Not at all. If I can add, Judy, you did a fabulous job in preparing that orientation report, and
I will be attending the conference, and I'm going to be attending the executive board, which is followed by the member assembly. I have no idea what's happening in the election, because that was going to be Lois we were going to be voting for. So I would assume the second vice president would be up for it, but I guess the nominating committee, and I guess Jonathan would be the only other person that still has any contact, you know,
Maybe
in
we
depth.
could get some more information for the.
Yeah, well, anyway, I'll be glad to serve as a delegate.
Awesome, thank you.
Share in the sentiments of the new board members as well, that I'm excited to be here. I thought all the presentations today were very informative, and I look forward to working with you all and learning as much as I can. So, thank you.
Wanted to, and this is kind of in follow-up to what Judy said, when we had our consultants come, a lot of the dialogue was how do we make our relationship between staff and the board more of a dialogue and less of a presentation style. And our meetings have evolved into presentations. So during our study session where we talked about format and what could we do differently, a decision was made that the board meetings would continue to be presentation style, but we would try the committee a whole. We already had these speakers all lined up, but starting in June, we're going to have it be more of a circle where we sit around and have open exchange of ideas, dialogue, conversation, which, you know, we have an audience. It'll be awkward, I think. We'll try it. I mean, we just don't have many opportunities for us all to sit as a group and do strategic thinking, looking at our data, looking at outcomes, and talk about it. So we're going to try some different formats, which will feel different for all of us, feel different for those who come, and we will, you know, keep switching it up until it's something that works well for everybody. So just a heads up that when the June Committee of the Whole meeting comes, it won't be this layout. It'll be more of a circle for conversation, and we'll see how that looks and feels and how that works for everybody. So we'll start in June, and I'll send you some emails between now and then to get agenda, like what should we start for our first dialogues and things like that. So a little different format, but I hope it'll be positive for everybody. Don't say anything. I think this is the first time I ever said anything.
Typically, there hasn't been a director's comment,
it's
but board
director's
member
comments.
comments has been an aspect, but not director's comments, as also with approve the agenda.
Anyway, I hate to end this on a sad note, but you've noticed Kai has been jumping back and forth